Hello, everyone. Thank you so much for these really fantastic presentations. I want to remind everyone in the audience to go ahead and put your questions in the chat, but I'm going to go ahead and get us started. And this is a question for everyone. And I'm going to start in the order of the presentation. So what do you see it's like either the key takeaway or the greatest opportunity for using electronic health records for improving patient care and outcomes? Dr. Patel, do you want to start us off?
Sure, thanks so much. I appreciate it. So certainly I think this idea that changing the floor in many ways, like really developing shared understanding of where a patient is, what options look like, how to report symptoms. So this entire place is essentially that we provide all the information and can make good decisions about healthcare together. And so really to change it from patriarchal to much more patient-focused decision-making. It's a great opportunity.
Thank you. Dr. Bosch?
I would agree. I'd say we are rapidly progressing through a period of more patient-centered orientation across many of the ways that we deliver cancer care, whether that manifests through navigation, through care coordination, through advanced care planning, through many of the care enhancements that are now covered variably in value-based care arrangements. We are thinking much more about connecting with our patients and using the electronic tools we have to do so. And I think the virtual care revolution has really accelerated this. And so I think to consider the functionalities of EHRs and how they can help us better to communicate both at and between visits with our patients, collecting the information that's salient to really meeting patients where they are and to addressing the problems that are most important to them is probably where this needs to go. And I think to have platforms that are flexible enough to do this, that have these functionalities, whether it's an enhanced portal that's easier for patients to access or inclusion of patient-reported outcomes, which is my area of interest, I think that vendors and technology developers need to have incentives to include this kind of functionality and this kind of openness to enable our practices to be patient-centered.
Thank you. Dr. Osterman?
Thank you. I'll continue along the lines of Dr. Bosch and say that I think we're really at an inflection point where, because of some really key pieces of legislation, we've seen more and more data not only go into our health record, but go into our health record in a format that we can make really large differences on. And I think one of the grand challenges going forward will be migrating from thinking about just the single patient in front of you, but how do you manage entire populations of patients? And as we get more and more data, I think it allows us to put guardrails around and make sure that no patient gets left behind or gets inappropriate care, that we can find patients when new treatments become available. For instance, a new treatment becomes FDA approved. How do we find all of the patients that would qualify for that and alert other providers? I think these are challenges that we're going to be facing going forward. It's a great opportunity.
Thank you. Dr. Hupstrack?
Hi, yeah, I think we're taking the right steps to move forward. I think that there is more work to be done, and we're going to be learning how to better use technology we have. We may develop some new technology, but just using the technology we have, particularly in the area of human-computer interaction, that is gathering information from both the providers and the patients and opening the communication between them, and then adding on top of that guidelines, AI, whatever is necessary to better focus that flow of information and decision support. So I think we're still have a lot of, while there may be a lot of improvement, I think I'm encouraged by what I'm seeing. And I think there will be an inflection point where we suddenly make sense in a way that it hasn't made sense yet.
Thank you. Dr. Tavorian?
Thank you. I think I agree with what others have said. I think that amplifying the patient voice and the patient experience and bringing that to bear front and center within the EHR has tremendous potential. I would caution, as others have, that ensuring equal access to those opportunities is critical. We have this tool potentially that could help to address implicit biases and assess the patient experience objectively to some degree. But to the extent that patients are interacting differently or differentially with the EHR or its applications, it could worsen or entrench these disparities. So I think there's sort of both an opportunity and a challenge there.
Yeah, I want to follow up on that question or that comment. It's been raised by a couple people in this session, but also in the previous one about this idea of making sure there are guardrails so no patients are left behind and that access is equitable. Dr. Tavourian, you mentioned you had some comments about that. Would you like to expand?
Well, I think we're beginning to look, this is toward Dr. Bash's talk in his area of expertise, but we have, like many cancer centers, a large patient-reported outcome monitoring program that is evolving and has had to deal with certain challenges, for example, with the pandemic. And we're beginning to look now at several years of experience with this program and trying to understand better what groups are reporting and how their reporting patterns are changing over time. And have started to uncover some disparities in who reports when and what they report. And trying to understand those and again, to sort of proactively address them, I think is so critical, because to ensure that the benefits of these sorts of systems accrue to really all participants, we need to make sure that people are participating equitably. So that's one example, and I'm sure there are others.
I can add in and give an example. So during the pandemic, in our health system, initially, the only means for patients to sign up to become vaccinated was through the portal. And we recognized very quickly that many of our vulnerable patients with cancer receiving active cancer therapy were not regular portal users, and therefore we're losing the opportunity to have timely vaccination, particularly in vulnerable populations, again, that may not have been as connected. And so we then pivoted and actually used information in the record to identify those patients who were not using the portal regularly or who did not have an email address registered in our system. And we called those patients manually with our hospital staff in order to sign them up in order to gain their vaccination. So I think it's an example where the digital divide can unintentionally translate into furthering health disparities if we're not cognizant to meeting patients where they are or providing means of communicating with them that are again in the patient's zone of usual communication.
Dan? Yes.
The one caution I have is that we shouldn't prejudge who's going to be disadvantaged and who's going to be advantaged. It's an empirical question. We keep being surprised. So when we studied health records many years ago, we thought the older doctors would never be able to use it. They were the best at using it because they had free time to do it. It's the 50-year-olds that stumbled because they were so busy in their careers, they didn't have time to learn it. And similarly, I showed the slide of the patients who had never used a computer yet. They were doing among the best in doing their own pulmonary function tests. And so if we go in with the preconception that it's economics, we may miss other factors. It may be personality is the single biggest influence on whether you're successful with this or other factors. So it's an empirical question. We need to make sure we bring everybody in.
Do you have any specific suggestions for how to create the improve patient ability to have better functioning? I mean, are there standard approaches for helping patients to use their portal, and how widespread? Yeah.
You know, in my projects, I rely on my colleagues from human-computer interaction, and they have spent years learning how to do this. And so there are a series of fields that are exactly designed for this. Some of them not actually doing that much in medicine, but we can pull them in. So I'm not the expert on that, but I try to pull in people who are.
Thank you. Okay, so the next question is related to better integration of wearable device data. Anyone want to comment on how well those are being integrated, especially across systems?
Not so well?
Any thoughts to
I
how?
mean, let me point out, I pointed at a study that we did that had people with a smartphone take a picture of their meal, which was crowdsourced to say the calorie count of carbohydrates, and then predict their glucose in 2 hours. How did we get their finger stick glucose into the smartphone? They typed it in because we couldn't, it was just too inconvenient to connect the glucose monitoring device to the rest of the application. So there's an example. You would think that that would be the easy part, and finding the calorie count on a meal from a picture would be the hard part, but it was the other way around.
Yeah, we don't do it. We do a lot of patient-reported outcomes collection, which often is bundled or grouped with wearable devices, for example. But I don't see it being done either.
Similarly, we have several programs that incorporate it into research arms, but not as a part of standard of care.
And what do you see, this is for Dr. Bosch, what do you see as opportunities for enhancing patient-reported outcomes going forward? And anyone else who cares to respond, but I'll go with you first.
Well, I think, as I said in my remarks, I think reimbursement is at the top of the list. So, in the AMA, when CPT developed the most recent codes for patient therapeutic monitoring and patient and remote therapeutic monitoring and remote patient monitoring, it did not accommodate the kind of PROs that we use in oncology for a variety of reasons. And so I think any advocacy for CPT to modify those codes to make them amenable to PROs, I think would be probably the most fundamental important change that could be made to move this forward. I think the second is PRO. There's been a lot of discussion of including PROs as part of the next iteration of the oncology care model at CMS. And so I think that for PROs to be meaningfully included within the next OCM, in the future to be named successor to OCM, I think would be important. I think the third is that, the development of standard practices, which I think, again, will evolve as it starts to be paid for, is essential. We have learned over the past, 5 to 10 years, some best practices, both around the patient interface piece, but also around the staff and clinician interfaces or visualizations in order to make these systems more feasible. I think all of us probably have experienced PRO implementations that have been, a real challenge with, patient adherence rates in the 20-30% range because they're not done well. Like any care enhancement, right? Any care enhancement, if not done well, will not succeed. And we also have seen big successes when, we meet patients where they are. The technology is easy to use. There's not a complicated password. We remind the patients that this is an important part of care, where we react to the information in our clinical practice. All of these tenets, I think, are fairly well known. And I think, again, once there's a business model in place, I think there's enough knowledge for this to become a standard way that we do things.
Dr. Osterman?
Just to follow up on Dr. Bosch's response, and actually also with Paul Klutz from FDA's comment in chat about how do we deal with heterogeneity of these PROs and mobile devices. And I think certainly Dr. Bosch and team have done a great job in making very specific definitions on PROs and PROMs. We're not there with probably patient-generated health data yet. And as we think about how we incorporate these into the medical record, especially with an eye towards interoperability, I think I would just encourage either researchers and or companies to also figure out ways that we can capture the metadata around those data. So whether or not this was data that were collected from a specific smart device, et cetera, so that even if we may not have a data standard today, maybe we can impute that data standard going forward if we have good metadata around those. Otherwise, I agree with Paul, we're going to be in trouble as far as making sure that a heart rate from one healthcare system is equal to a heart rate at another healthcare system if those are obtained by different devices.
Anyone else care to comment?
Robin, I would just add, sort of piggybacking off of Larry Schulman's comment in the initial session, that clinicians are overburdened now more than ever. And when optimally implemented, clearly there's an opportunity for this to help workflows. But when poorly implemented, it can worsen workflows. And I think that these sort of unintended consequences are really important to consider when we think about the future of PROs.
Thank you. Anyone else thinking of some of the challenges that we may face going forward with not only PROs, but other enhancements from the patient perspective? Dr. Patel?
Sure. So, a couple of things. One, I think we are often burdened in studies and sort of getting people with cancer to report their outcomes or to sort of nudge them to log in and to give us information. So truly using the EHR as a repository of information, not only a personal healthcare record, but an area in which you can find information, right? And so we talk about enhancements in which hoverboards might have a link or a hyperlink to another website with information about what this language means, or about guidance towards a recommendation for a cholesterol level, for example. And so that piece of, yes, it's a huge document, but are there functionalities that we can really use to enhance understanding? I think might make the work for everyone a little bit easier and more attractive.
So I'm going to...
I would just add quickly, an item on financial toxicity as well is another element we haven't talked about.
I'm happy to have that conversation. Ethan, you want to follow up on that?
I don't want to take up too much bandwidth in the conversation. There are a lot of us on the panel. I would just say that there are examples of systematically eliciting patients' financial status or either financial hardship or perceived burden, electronically, and conveying that information to the care team, either to a financial navigator or social worker, in order to connect the dots on challenges patients might be facing. So it's another area where directly eliciting information from patients, bringing it into the record, and then conveying it to the team may bring issues that I think probably all of us on this call are interested in around patient financial toxicity and burden.
Thank you. Thank you. I will say it is a key interest of my own, so I'm always happy to have that conversation. So we have something from the public chat from Louise Russell, and I think this is a really important issue. She says an earlier speaker said EHRs always add, but never subtract. Any thoughts about opportunities for subtracting? Are there some functionalities or some pieces of information that could be subtracted?
I'm happy to start on this one. I'll continue to stand on the soapbox of interoperability and say I absolutely love when I can access a new patient's medical records across healthcare systems. And that we've seen continue to become more and more tightly integrated. Even just 5 or 6 years ago, we would have only been able to point to a few cities in the US that had really robust health information exchanges. And I think we've seen a big growth in this space where I think at least the EHR has made my life better.
Anyone else? Thoughts about where we can subtract?
I think the clinician note is another opportunity, and I think with the open notes movement and also with new billing requirements that move us away from needing to document certain elements of the history and physical and more towards shared decision making, clinical decision making, and time-based billing. I think we may see slowly a transition away from these arduous, complex, very, very long notes to maybe more meaningful notes that can promote a dialogue between patient and clinician.
Yeah, we've definitely created a situation where clinicians have over years felt increasingly compelled to prove that they looked at the lab value by repeating it. And then you have cut and paste. So then you have a whole MRI scan, cut and paste into a doctor's note, for example. And then you have to sort through that to get to their assessment and plan. And obviously there are technical solutions. If you look at something, record that they looked at it without having to cut and paste it into the note, although depending on the auditing requirements, sometimes you literally has to be cut and pasted. And knowing that you looked at it is not sufficient. So changing those rules can allow us to put less in. That's one of the initiatives for that American Medical Informatics 25x5 to try to reduce the documentation burden. The other is over time, you tend to gather more and more decision support rules, and you really need a mechanism for getting rid of the ones that are not working, and whether that's through real-time randomization, kind of as websites, as web providers use A/Bing things and see which ones can be gotten rid of. Some can be obviously cleaned up, and some we think should be cleaned up, except that they're not actually working and they ought to be cleaned up anyway. So I think there's a couple of things, but I agree it's always harder to take away than to add.
Mm-hmm, mm-hmm. As you were talking, I was also thinking, like, so what organization supports that type of evaluation for taking away rather than adding? And, what are the options for moving something or strategies like that forward? Any thoughts on that? I mean, other than Jamia or others?
I think that as we reduce the documentation burden, there's going to be so much pressure on vendors to adopt that will be sufficient to drive it forward. Can it be top down, like from government mandating? Like, I don't know. I'm a little afraid of that. I don't know what would happen if we tried to top down. I think it's something that needs to be iterative to figure out what we can remove. So there may not be one organization deciding. I think what can happen top down is different regulations to change how notes are used, so we're not putting all that stuff in.
I wonder if it could be top down within systems, health systems. We've experimented some with a common oncology note, for instance, and whether you could sort of customize to the local setting, but not something that's more draconian than that.
Yes.
And then I guess another sort of follow-up question is how, if you do find strategies that are effective, or you do find within a system something that is effective, how do you share, spread, disseminate those sorts of findings so other systems, when we think about a learning healthcare system, ideally it's not just a single system, it's something that's spread more widely. Anyone have thoughts on that about disseminating effective strategies, either for reducing documentation burden or for more strategies for improving availability of things that work for patients? I recognize that was kind of a broad, rambling question. So any piece of it that you're interested in responding to.
I might just put a quick plug in for the importance of studying all of this. I think the EHR reaches so many patients, and there's an opportunity again to pragmatically randomize different design elements and actually answer questions about what works well under what circumstances and when. And I think this is a little bit of a cop-out answer, but I think if we rigorously assess this within a clinical trial setting and then publish those results, I think that's at least the first step for dissemination.
I mean, there's traditionally been a struggle between more open approaches, software versus closed approaches. And I wouldn't say the open approaches are winning in any way. And so what happens instead, I think within a vendor community, they're sharing, and the vendors that do best are the vendors that promote that sharing, because they know that then has a good effect on their customers. So that's where I see most of it happening today.
So an important opportunity for vendors to play potentially a larger role within the communities they serve.
Similarly with professional societies, so NCCN and Amy referenced this in the chat on a white paper that the NCCN EHR Ad Board published on the current state of patient-generated health data. So I think George is right on that. It's in some ways the EHR vendors, but then also the professional societies have a role to play in this as well.
Thank you. So we do not have any additional questions in the chat, and I think I've sort of run the gamut of many of the questions that I had for you all. Do you all have questions for each other, or any last comments you'd like to share? And Dr. Schulman, I see you just turned on your camera. Would you like to ask a question of the panel?
Well, since I was the one who made the comment at the last session about taking things away and not just adding things, and you've made a couple of comments about that, I would reiterate the fact, and Ethan talked a little bit about this, that as we plow more data into the EHR and, patient-reported outcomes and, some others are included in that, those data need to be optimally accessible to the clinicians in ways that are facilitating rather than making things more complicated and more burdensome. I still think we have a long way to go in how we present data that is efficient and useful. And so I think anytime we think about whether it's patient-reported outcomes or other new data, if you will, relatively new data that are being put into the EHR, we need to think about how to do that in a way that's positive and not negative. And the other thing I would say is, that there really needs to be a focus on safety. And, what are we doing that actually makes things less safe rather than more safe? And Sam made the comment that we need to test things. We need to find out what's actually making things better versus what's making things worse. And we all have our opinions. I always have my opinions, of course, Sam knows, about everything. But we need to find out what's making things better and worse. And we're not really doing that very well. One of you, and I can't remember which one, mentioned the best practices alerts or other prompts in Epic, which we're all clobbered with. And everything just stays, and I think we've not done a good job at that. So there's a lot of tremendous opportunity, but unless we're very careful about the further evolution of EHRs and how we process the data and how we make those data available, I'm just concerned that they won't have the advantages that they potentially could have. I mean, Ethan has showed tremendous impact on PROs in the right circumstances, but it could go the other way if it's not well done.
Could I reflect on Larry's comments?
Yes, please.
As usual, I agree with everything that Larry just said. I think so eloquently, it's true. I mean, I can say, so in my role as a division chief, I'll say the biggest dissatisfier to physicians and APPs and staff is, it's all the burden of documentation and workflow information flow in the EHR. Whether it's dealing with scheduled orders or whether it's, spending your weekends finishing your notes, it's a huge burden. However, some of that burden is the burden of cancer care, which is really complicated and difficult. Our patients are very ill, they're very acute, they're very complicated. Coordination of their care is very complicated. And some of this is the unnecessary burden, related to our informatics systems. And I think parsing it a little bit is useful because, again, we can be dissatisfied. I mean, I can be dissatisfied because my pager goes off, but I'm glad my pager went off because I need to know the information on the other end of my pager, right? So it's complicated. One thing that I'd say to complement Larry's comments is that, an essential piece of contemporary cancer care is team-based care, and making sure that the right person is getting the right information to do the right thing. And, I think an observation we've made is that sometimes because of the rigidity of the EHR and workflow in the EHR, inappropriate work is dumped onto the wrong person, often an APP or a physician, or sometimes a navigator or a coordinator. And I think, an essential piece of team-based care is that people unweight each other by doing what's within their job description. And, I think thinking about how the EHR can facilitate rather than, mess up team-based care, I think will be essential to considering workflows.
Anyone else want to comment? Yes, go ahead.
Yeah, part of what's going wrong is we're not actually assigning costs accurately. So every alert costs money. I once did a not so good, a very quick study of what does it cost when we add a radio button and it gets disseminated around the country, and I came up with $16 million. Now, maybe that's not exactly right, but there's a cost to everything we do, and we should be saving $16 million before we add that radio button, or at least take that into account. As we create all these best practice alerts or medical logic modules or whatever, again, they all have costs, but we're not really accounting for it, and it's often seen as free. And then you have a new initiative and you want to get to it quickly and you add it on. So, and also the cost of reading the long document that you just cut and pasted into. So enlightened organizations that can step back and say, okay, what is the actual utility or cost of each of these alerts? Then there'll suddenly be a huge incentive to reduce the number. If nothing else for employee satisfaction, but more important for clinical care.
And the other thing I wanted to just mention is the sort of amplification issue of a busy clinician. If somebody is seeing 20 patients in a day, which is not atypical, and because of the way that the EHR is constructed, it takes 5 minutes longer than it should have for that encounter. And we can all imagine where we might cut 5 minutes out if things were done a little bit differently. We're talking about an hour and a half on the end of that clinic day that might not have to happen. So this amplification all makes perfect sense when you're thinking about one patient. If we also have one patient a day, these conversations would be much easier. But if anything, based on workforce projections that I mentioned at the end of my talk, we're all going to have to see more patients, not fewer patients, in the years to come, because their patient numbers are growing faster than provider numbers. And I do think we have a lot of opportunity to make the EHR work much more efficiently than it has. And I think we do very little in that regard. So I'm all for adding the critical elements, whether it's PROs or other information that we might gather. But I think we need to take much more seriously ways to make the EHR more efficient. Some of it's documentation, but a lot of it is just where the data is, how long it takes to find it, and sometimes never finding it. I don't think we've done a good job. And I think other industries have done this much, much better than medicine has. We could speculate on why that is, but there's a lot on the line here. And I think we need to, as a profession, just do much more in this regard. Not just
I'll just add to that, and the importance of making all of these changes and make sure any evolution is patient-centric as well, so that when we're thinking about the costs to providers, we're also thinking about the potential costs to patients. Okay, so we have a few more minutes on this panel. Any last thoughts from anyone before we wrap up and give people an opportunity to grab some food for lunch? It's always a challenge being the ones right before lunch.
So I did want to remind everybody, we are taking a lunch break, as Robin mentioned. We believe in certain, principles of life, like having time to eat and relax for a minute. We will reconvene at 1:50 Eastern Time. It's 1:50 Eastern Time, promptly for the next session. And I want to thank Robin and all the speakers in this session. It was really, really good. And we covered a lot of territory. We didn't solve all the problems. I won't blame all of you for that, but we all have to collectively try to solve them in the future. But wanted to thank everybody, and we'll see you back at 1:50.